Okay. All right. I hope everyone has some refreshments. We can start. So I have been given a task, and it's a little bit difficult. I need to combine. This is a complication course, and I need to speak about imaging. Probably it is a little bit difficult to link them both together, especially yesterday some of our colleagues has been traumatized with what they have seen of a complication and perforation. So the way I thought I'm gonna link things together is to share with you, bear with me for a few pictures that you will see for the time being. So this is a day that I started with a patient having this angiogram. This is a patient who was having angina and was put on medical therapy, and on my table now, he's completely pain-free. There is a very ugly, I wouldn't say very, very ugly, but there is a lesion in the proximal LAD. Should I stent? And then a flashback comes to me. You remember your patient you stented last week. He had a stent thrombosis. And now he's pain-free, but this is very proximal LAD.
Dr. Fawaz, is it okay like this?
Yeah, because things will come now. All right? So is it really, should I continue stenting or should I defer? So I need something to help me into that. At the same day, you have a patient who presented with LAD diagonal like this. You think this is going to be an easy and you will finish quickly. And while you are wiring the LAD diagonal, we have one lady called Sharon. She is the sister of the head cath lab. She comes and tells you there is a primary coming. I said, okay, fine. So you put the wire, you dilate, and you end up with this. Oh. Okay? So that's not going to be my day. Anyway, you said, let's carry on. You go here. This is a 3-vessel disease, refused by surgeon, MDT done, fix the RCA, fix the circumflex. He has this LAD lesion. You struggle with it so much to an extent that you've seen guide is not supporting. You have a guide liner. You stented the proximal LAD, and you are having a lesion in the distal. You want to cover it with a stent. You put the stent, and this is immediately what happens after. And remember, I have a primary coming on the way. So that is not going to be my day. Then the primary comes. We manage this. This is the primary. You put the guide, total occluded of med LAD. You wire it. You establish a flow. You feel some hazy. It's not expanded very well. You do the IC stent or stent boost. You feel that you need to postulate. You take a high pressure balloon and you dilate this, and then you get this. That is not going to be my day, right? So you can imagine now when you have all these things happens to you, probably in a one day, okay, or in a different days, that is not going to be the way you think about it. So the question you have to ask yourself, you have too many questions you will be asking yourself, but one of them is, you're going to say, could this be avoided, right? Keep this question in your mind, and let's go to the next slide. The other things that comes to you is this question. You remember whenever you have a video game, at the end, if you don't pay, they tell you, do you want to quit or you want to continue? So that's the same question you will be asking yourself, right? After that day of all complications, you will ask yourself, should I quit or continue? So if you choose to quit, you become a loser. You stay in your comfort zone and you do what you want to do. Okay, straightforward cases without any movement. If you decide that you want to continue this game, you are going to get out of your comfort zone. You're going to move to where the success happens. However, you need to switch the traffic light signal. You need to stop, think why this has happened to me that day, and then you need to proceed. And what I am planning to, my presentation today for you is how the imaging, particularly in this presentation, OCT, saved my day from having a lot of complications down the line. The goal of this presentation will be to enrich your knowledge and practice of utility of imaging, I'll try to demonstrate some intravascular imaging, mainly OCT here, that could predict complications. And I will discuss with you real-life cases. I'm not going to give you theory because I have seen my colleagues have given you data like a lot. So today I'm going to try to give you a real-time cases with a messages at the end. So I will not have a conclusion messages at the end of presentation because at each case we will have one. This is an octogenarian man who's diabetic, having all the risk, female, having all the risk factors, presented with non-STEMI with hypokinesia anterior wall. The first thing you want to do is to look at the angiogram. And I would actually love to have this an interactive session, and I have the time here. I try to control myself. So if one person wants actually to stand, or the panelist, to describe to me where exactly he's going to treat this patient with. Any candidate? You have an anterior hypokinesia, EF35 non-STEMI. Which is the culprit, and is there anything you want to highlight? Go ahead, doctor.
So, first of all, this is a left coronary system injection. You have LAD, severe proximal, mostly calcific stenosis. The rest of the LAD mid-segment also has looks angiographic significant stenosis. These are all codal views. And then you have the OM1 tight stenosis. And the PDA, it's a left dominant system, and the PDA and the PL doesn't show any significant stenosis.
Perfect. So if I ask you here, the money is in the LAD, you agree?
Sure.
Okay, so the question is, do you think that this is going to be a straightforward lesion? Do you need to modify that?
No, I think I'll do imaging, and according to the imaging, I will put my treatment strategy.
But we should agree, I mean, we are biased because this is an imaging session, but we should agree that some of us would actually just wire, balloon, and test the lesion. Am I right? Okay, so I actually pulled the OCT catheter, and I am going to keep this running while showing a couple of important things that probably we have missed or did not recognize it on angiogram. We know there is a calcium by the angiogram, but we don't know, this is the distal reference range. You see a thin plate of calcium. For those people who are not familiar with how the calcium looks like on OCT, you can see the island of calcium, thin plate. This could be easily treated with regular NC balloon. However, you have a calcium nodule here extending into the lumen, which you can see it here. The tightest lesion, this is where my pre-dilatation I have done with a small balloon, so you can see some dissection. But what is very important, and this is the message in this, the very ostial part of the LAD, you can see this calcified nodule. This is gonna be a nightmare if you don't recognize it. Because what any interventionist will do is after deploying the stent, he will see a waist, he will go with a higher pressure. And this is where the perforation happens. Remember, this is actually after modifying this nodule with IVL, this is how we can get a good lumen gain and deploy the stent. The result angiographically looks good, yet there is still some hazy here. But because of my background of the OCT and the nodule, I stop myself and say, that is enough. Just imagine if I go with a high pressure 4-5 or 5 NC balloon here, and I perforated the artery here, I'm going to be in trouble because any cover stent is going to jeopardize and cover my circumflex, which is, as Dr. Wall said, this is a very dominant left circumflex. So, just a brief point, since we have discussed about nodules, this is a very important because people say, okay, you talk about nodules, what types of nodules do we have? We have the eruptive and non-eruptive. The eruptive is very simple. It is an irregular surface. This is more malignant type, usually comes with acute coronary syndrome. Usually this is the one which we need to treat if we have to in the setting of ACS. And usually we get better result with it compared to the other one. The other one is non-eruptive, smooth. You better avoid it if you can. And it's going to be a problematic because modifying the nodule in general is still we don't have a consensus for that. So some people will say orbital atherectomy is fantastic. The others will say rota is better, or IVL. We don't have a consensus. You do what you can to modify it. But the message I want you to remember, if you can leave the nodule away and fix the artery, that's the best, because the most restenosis happens at the nodule site. So the imaging here helps me to recognize the amount of calcium, but not only the amount, the type, and avoid high pressure dilatation, which can cause a trauma and perforation. This is the second case. So this is a 56. He had a previous PCI to RCA with a preserved ejection fraction, and he's coming again with angina. This is his angiogram. If you remember, probably some of you have seen this yesterday in the complication. All of you, or most of you, will be focusing on this is the stent and there is a restenosis. So we have an ISR and we need to understand what is happening. Class 1 indication, if you have failed stent, you need to understand why the stent failed, right? So we pre-dilated a little bit and we did the imaging. I'm going to keep this running of the OCT distal to proximal, and I'm just going to focus on a couple of things. So number one, when you have restenosis, you want to know why the stent fails. So this is the previous stent, as you can see it here. And there is definitely some growth of the tissue inside. There is some dissection. That is because we have pre-dilated that. But what I want you to notice is behind the stent, there is a calcium. Can you appreciate this? That is, keep this in mind. Look at the proximal part of the stent. The same stent, you can see that the growth inside the stent, again, this is the stent, it is heterogeneous. So it is not all homogeneous type. And you can see that there is a calcium inside and calcium outside. So you know by that there is a lot of calcification that needs to be treated within the stent. That's one point. Now, what OCT helps me here, or the imaging in general helps me here, is to detect that you don't have a problem only in the stent. In fact, you have a problem proximal to the stent with this area. You have a concentric, thick calcium 360. Be careful to this area. All right? So we know the mechanism of the stent failure here is what is called as a new atherosclerosis, and we know that this is a heavily calcified. Now, we have a concentric calcium, we have a thick calcium, we have a long calcium. This is an important information when you do imaging to classify how bad is your calcium and choose the proper calcium modification tool, which we will talk about it later. Now, what has happened in this case, probably if you remember, and I'm going to walk you through, took wire, pre-dilate, multiple small balloons didn't work, IVL taken, IVL ruptured, and we got a good result at this point. Still, we did not modify the area proximal to the stent. We took an OPN balloon 4O, size 1:1 to the vessel, and I'm going to keep this running. So you've seen that we've done the OPN to this area and it is fine, and we pull the balloon to the proximal segment. Remember what was there in the proximal segment, right? And what has happened is you dilate it, and then patient screamed. And this is what has happened. So doing an imaging is not about doing it, analyzing it properly and expecting what could be the problems. So this was managed, managed with the stents, cover stents. And for those who are not familiar with how the OCT looks like in a cover stent, that is a cover stent. So this is the area, you don't see anything behind it. While the proximal segment, which is going to come now, you will be able to see things. This is the normal drug-eluting stents. All right? So the message here, OCT help us to understand what is the reason for stent failure, and we react to that because we've seen calcium behind the stent and we use the IVL, but we probably underestimate the concentric calcification in the proximal segment, and this is where the mistakes happen. Now, probably most of you are familiar with the rule of 5 of imaging guiding calcification. So if you have any calcium, which with an ART more than 180, that is 50%, so 5, so half of the arc, you have a thickness of more than 0.5 millimeter and a length of more than 5 millimeters. These are the points 4 out of this, if you have 4 or more, these are indicators to use atherectomy devices versus IVL. Simple balloon is not going to work. Now, there is a modified a score or calcium score, which is the rule of 3. It looks at the calcium from a different perspective. You have to have a maximum arc of 270. If you have 360, that's 1. So this is 1 point. If you scan all the calcium along the vessel and the minimum calcium thickness is more than 0.3, so you don't have 0.2 or 0.1, it's all of them 0.3 and above. This is the second point. And the third point, if you have more than 3 millimeters calcium of 270, these are the predictors of bad outcomes. If you just treat them with a simple balloon angioplasty, you need to go for modified plaque. This is a third case, and I'm trying to stick to the time. If we have a discussion, it will be later on. This is a young male, smoker, presented with a chest pain, inferior-posterior MI, thrombolized. Because of ongoing chest pain, they referred the patient to us. We took him to the cath lab, and this is the first angiogram. Patient is still having chest pain. Definitely the problem is in the circumflex. I have a lot of things here. I have a hazy area in the proximal circumflex. I'm not sure exactly how much is it because of a spasm, how much is it because of clot. So I've taken an export catheter, wire both, then took an export catheter. The proximal segment has improved a little bit, get a better in the AV circumflex vessel, but I'm still do not know how much I need to treat. Do I need to treat from down all the way with 2 stents, or should I stick only to the proximal, and this is only a spasm and a clot? So I'm not really sure about it. So what I've done is I took the OCT catheter down. And I apologize that this is a very old run, but this is actually from the distal OM back to the mid-circumflex. And I will let this run. If anybody wants to comment, we can. So this is the first run. I want you to see if you see anything here that is you're not happy about. And this is the second run. I changed the contrast, so that's probably, this is going to be looking better. And this is the run from the mid to the proximal circumflex. Anybody wants to highlight something, please, from this OCT? I just wanted to be a little bit interactive. Anything is not happy about something, or everything is going fine? Who was it? Okay, well done. So one thing, at least if you did not see what is the pathology, you should expect a clot. And there was no clot. There was only some swirling of a blood. So this and the intima media were actually very nice. It does not go with the plan that you have it in your mind, that this could be an ACS presentation with a clot. So what you can see is that you have the intima media adventitious quite good, and you have a black discoloration at the back of the vessel. And that is the hematoma. And that is the hematoma. Now, if you follow this run, you will see some disruption in the intima, where is the connection between the lumen and the false lumen. And did the OCT saved me that night? Absolutely. Because you can imagine, this is all hematoma. If you go to the angiogram, this one, and if I was so clever and put a stent here, okay, and then follow that with a stent up to here, a problem could be that I propagate the hematoma, toothpasting it to the left main, the patient will crash and die, and then I say, I don't know what has happened. Because the hematoma now confined to 1 vessel, I'm going to make it to 2 vessels. So definitely this is a saving OCT for me. So I left the patient on medical therapy, stays for 3 days in the hospital, brought him after 3 months for a checkup angio, and that's it. Saved the patient from a stent, actually saved the patient from being dead now. So we have different types of SCAD. You can always review that. The most common one is probably the one that we have it in our case, because it is like a diffuse stenosis. Going backwards now, you always, as an interventional cardiologist, has to keep SCAD in your mind. But be careful that some scats can be like a total occlusion. Some of them can be focal, where like an atheroma disease. So imaging helps me here to identify the pathology, recognize the problem, stop me from causing harm to the patient. The case number 4, I label it an OCT and complex anatomy. Now, I like the discussion in the previous talk. A lot of people say left main, severe disease, CompEdge is always better. Well, stick to the latest data, which is going to come now after this case. So here I need a voting from you because I don't want you to sleep. It's too early. So this is a 65 years old male, diabetic, hypertensive, dyslipidemic, referred with exertional fatigue and MPI positive. Good LV function. This is his angio. His right is non-flow limiting disease. The patient has this. This could be actually used also for the previous discussion whether left main is significant or not. But I want a candidate, please, to go and take the mic and tell me, what do you see in 30 seconds? Any candidate? Please.
Let's make this interactive. So what I can see angiographically here that there is dense calcification. Just before do the contrast, there is dense calcification of the proximal AD and the circ.
That's it.
There is diffuse high-grade atheroma in the osteoproximal LAD. It seems for me quite significant high-grade stenosis. And followed in the mid-segment by hazy lesion, which most likely to be calcified plaque. There is a moderate stenosis in the osteoproximal circ with doubtful significance. It's in the borderline range. And then followed by distal segment again, like 60 to 70% stenosis.
Good, thank you. Now, I'm going to ask you here, as I want show of hands, how will you manage this case? Who's going to treat him medically? He has good LV functions, he has an MPI positive, some angina symptoms. Medical therapy, raise your hand. Oh, definitely I am an intervention group. Okay, fine. Second question, who's going to go for a PCI? Perfect. And who's going to take the patient for CompEdge? Good. So the patient we discussed with him, Dr. Fawaz Mtairi, is suggesting you to go for a CompEdge. The patient refuses CompEdge. So now the patient decided for a PCI. Who's going to go for a PCI to mid-LAD only? That's tight lesion. Raise hand. No one. Who's going to go for a PCI mid and proximal LAD back to the left main? And who's going to do a PCI to left main bifurcation to stent? Okay. Okay. All right. So we need something to help us, right? Now remember, if you decided for PCI to LAD left main, like most of you will do, and you said, okay, I will see what will happen in the circumflex, okay, you may be in trouble later on, all right? So you need a tool to help you to decide. So this is actually the circumflex, because I know a lot of you will say, we need to see how the circumflex looks like. So now, after looking at this circumflex honey, okay, I think we need to move quickly. Okay, I don't need to wake you up now anymore, huh? All right. So if you look at this circumflex, this is an OCT pullback from the circ back to the proximal area. Is this something that you need to treat or no? So the lumen, beautiful. Okay, I'll come to that. But I want you to appreciate, I'll come to this. These are snapshots of the circumflex. So you have, this is the landing zone, this is the proximal, and this is the ostium. This is quite significant. I'll show you the number, I don't remember it, but I have it in the next slide. So this is by definition, it's not only about the area, but look about the amount of calcium you have to here. Can you imagine if you stent the LAD to left main and then you have to deal with this hassle, okay, of calcium. Now, this is the OCT run from the LAD to back to the left main, and we know that this is probably the culprit here because it's very tight. But what we, as you've mentioned, there is a calcification, but what type of calcification that we have? Look at this. This is your distal. This is your lesion as well in the distal, very tight. And these are the patterns of calcium. So again, we have an eccentric, more of a nodular. You have a concentric calcification here, thick, and you have what is called as an eruptive nodular calciumazine. Okay? And when this is, you see, this is probably correlated to the cause of the ACS. Okay? So he has this eruptive nodules, and this is at the LAD diagonal bifurcation. So definitely we have a thick calcium. If we apply the rule of 5 or rule of 3, this needs a proper calcium modification. I'm not going to take you into the modification, but this is just for answering those who ask me about the LAD and circumflex area. This is the area. So we modify. I'm not going to go into modification here, but just to show you what we've done. The only message I want you, I believe that IVL can modify the nodule. I show you one case earlier with a non-eruptive, and this is an eruptive nodule. I treated with an IVL, and it works very well with this. So this is just going through the case very quickly. After modification of the LAD, we stent this, then we stent the circumflex, then we pot. I usually like a lot, so we pot, recross, and then deployed the LAD stent back to the left main, repot, recross, kiss, and repot at the end. And this is the final result. Well expanded compared to the amount of calcium in the LAD and circumflex. You have the expansion is good. And what I want to focus about here is this bifurcation, because you need to get, we as an interventionist, we need to get a result as good as a surgery, okay, to be comparable. And this is the area. So this is the previous area, which was 2.7 becomes 5, and area of 3.2 becomes 7 in the LAD. This is how it looks like in a 3D dimension, and these are the results of the stenting. The result, or the message here is you can simplify your anatomy with imaging. You can guide your lesion preparation and avoid unnecessary complication that may happen when you try to stent something that you were not planning to treat. Very quickly about two things I want to mention here about October trial is a fantastic trial that deals with a bifurcation, and it shows that if you do imaging in bifurcation, this will have a better result, as well as a Renovate trial in complex PCI lesion. What is new actually, and I came across this last week, intravascular, this is in a JACC intervention paper released last week. Intravascular imaging guided PCI versus coronary artery bypass graft, or for left main and 3-vessel disease. This is exactly what we've been discussed earlier. I'm not going to go through this because I don't have time, but the result shows a promising result about imaging. If you do have a left main or 3-vessel disease, you have a comparable result if you do an intravascular PCI compared to bypass. So this is a signal. We need bigger number, more studies, but we have something that supports us now in the future. I'm going to end in this case. If you can just allow me 1.5 minutes more, please. This is a middle-aged male, anterior wall MI, LAD territory affected. This is his angio. Obviously, this is the problem. This is the problem. You go ahead, and this is a primary, so you go ahead, wire, stent. You got a good result, 2.5 postulated with a 3.0. You got the usual things, some clot distally, some clot on the diagonal, but the patient was fine. He was actually ready to go home, day 3, waiting for his papers, noontime. They called, they say the patient's having chest pain, ECG, re-ST elevation. So taken to the cath lab, this is the result. We got a subacute stent thrombosis. Okay, happens to everyone, no problem. So pass a wire, and stent, extra stent has been deployed distally, and the patient was fine, shifted back to CCU. Again, 3 days later, okay, before, I don't know why he chose the 3rd day, not anything earlier than that, but the 3rd day, again, he had again occlusion on the stent, wire, and then the operator decided, yes, it's time that we need to image. So this is the imaging after establishing flow and gentle dilatation with the balloon. So this is the distal reference zone. You can see some clot is there, but that's not very weird in such case. But what you can see here is you have some edge dissection. If you notice this run at the beginning, you have a huge organized, semi-organized clot that has been developed inside the stent, which you can see it here. And this probably was the reason that if you notice that there was a hazy part in the proximal part of the stent. So we dilated this very well and get rid of that. The stent was actually expanded very well. There was no problems with the stent, but it was the lumen inside. So could this be avoided? Probably yes. If we have done an imaging from the first time when the stent fails, that could have been avoided, because every time the patient's having MI, we are getting more reduced ejection fraction. This was the final result of this patient. Thank you very much. And I always encourage you all to join us in IPCI in Bahrain. We are doing a course for imaging OCT guided in our hospital. Thank you. Any questions?